cord begins at the medulla oblongata and extends down and comes out through the foramen magnum. These all terms that you remember.
Except the video one.
Actually,
Bob.
we haven't done the brain yet, so you're really not familiar with the medulla oblongata, but trust me, it's where it starts. Excuse me. Now, I love this drawing. This is a great drawing of the spinal cord. There's only one problem, and it's a logistical problem. You know, just the way this is laid out. You see this is all gray here and white there. The problem is that's not the way it is in life. In life, this is the gray matter here, and all this out here is white matter. Those are all axons, myelinated axons going up and down in tracts. So ascending tracts, which are afferent, and descending tracts that are efferent. Okay, so incoming sensory signals are traveling up these tracts out here, like these guys. Okay, and then the descending information coming from your brain to say move your arm or something like that is traveling down through tracts in here. The reason that the color is backwards is because of the background. If you imagine that the artist made this gray like it's supposed to be, and this white like it's supposed to be, would blend in with the background, and all you'd see is a gray butterfly. So the artist had to reverse the colors. But keep in mind that the gray matter is on the inside, on the horns here, and the white matter is on the tracts, or funiculi, or singular is funiculus, okay, if you're into Greek and Latin. Anyway, the spinal cord is divided up into two basic regions. The posterior aspect is sensory, and the anterior aspect is motor. Okay? And mainly we're talking about the gray matter in here. Okay? Because these, as I say, are tracts that are going up and down, so it's a mix of sensory and motor, depending on which way the nerves are carrying the signals. An easy way to figure out, this will help you in lab, okay, when we do the spinal. We haven't done the spinal cord. Am I doing it from Saturday, Friday? Might be. No, we did the brain Friday. Yeah, so we're doing spinal cord this week. So anybody do the spinal cord yet? No? Not yet. We're doing it Friday, so it's only Tuesday. Okay, anyway, the sensory portion back here, the posterior aspect, two ways to tell you have the posterior aspect. One of these things, these two aren't labeled on here. In the lab, you're going to need to know it. Okay? The posterior median sulcus and the anterior median fissure. All right? The fissure is a bigger crack than a sulcus. So the fissure is on the anterior surface and the sulcus is on the posterior. Also, as the spinal nerve, this is a spinal nerve right here. Okay? What it is two-way traffic. You've got incoming afferent signals going through and outgoing efferent signals. And they're wrapped up in connective tissue to make this spinal nerve. So, like this is a spinal nerve here, that's a spinal nerve there. So there's two-way traffic in there. You see these roots right here. The two roots, this being the posterior, right, because we recognize that this is a vertebra, and therefore the spinous process is on the posterior and the body's on the anterior. These two lines right here, these are the sensory incoming lines. These are afferent lines coming in. And these nerves going out are the efferent or motor nerves that are going somewhere. This being a cervical vertebra, and based on the fact that it doesn't have a bifid spinous, it's probably down by 7, 6, 5, something like that. In which case, those nerves, let's say it's 5 or 6 or 7, the outgoing motor nerves, the efferent signals there going out, would be going, for example, in your arm, 5, 6, and 7, okay, like that. And sensory information coming back in there, 5, 6, 7, as I'm touching my hand or near my elbow or my upper arm, that's going to be coming back through the sensory channels that are going through here, the sensory motor neurons there, sensory roots. Okay, but this is the spinal nerve with two-way traffic. So I always refer to the spinal nerve as being like the Long Island Expressway. You got two-way traffic, east and west. Okay. At any rate, that's basically the way it's laid out. So one of the things you can tell, and you can't really see it on this picture, but this shows us, this guy right here, the dorsal root ganglion. Okay, there it is, the nerve cell body. So the incoming, there's a receptor. This happens to be showing a stretch receptor in a muscle. But the incoming information is going through that sensory neuron, that afferent neuron, goes through that ganglion right there, the cell body of the sensory neuron, passes through there, comes this way, and enters into the posterior roots of the gray matter in there. All right, now this little guy here is an interneuron. We talked about interneurons when we did the nerves the other day, and we said that they're involved in this kind of activity. In fact, most of the nerves in the body, most of the nerves in the central nervous system are interneurons. Actually, they outnumber the other nerves, so that's an interesting point. Here's just one example of one, and what they're doing without any information having to be involved with the brain at all, they're connecting afferent signals coming in to efferent signals going out. And what you're seeing here is a primitive reflex, a simple reflex arc. Okay, basically the incoming information comes in. Actually, this is more of a stretch, muscle stretch reaction, muscle stretch reflex. This is, you know, when you, or tendon, Golgi tendon reflex. You know, when you sit down, you do the, you know, the knee jerk with a hammer. You can do it in the lab. Well, that's going through here. What happens is, as you're stretching the tendon, the Golgi tendon, and it's the tendon for your quadriceps muscle, as you hit it with the hammer, you're kind of stretching it a little bit, sending a signal saying, oh, we just stretched this. So if we stretch it, the idea is we don't want to overstretch the muscle, so we're going to get the muscle to contract. And doing it there gets your quads to contract. And when they contract, what do? You kick your knee out, because that's their function, is to extend the lower leg. Okay? So that's why that works. And what's happening, it doesn't require your brain. I can do it to a person who's unconscious. And they're going to get a reflex even though they're unconscious, because the brain's not getting involved. That interneuron is acting almost like a little brain, connecting information coming in to information going out. And what happens is, the information comes in, and of course the dorsal root ganglion tells us, if you see where it goes, okay, if I had no idea, I now know that this is the dorsal side of the spinal cord. This is the sensory side, because look where that dorsal root ganglion is connected to the nerve roots right here, going in. There's a synapse there, there's a synapse there. So this is a polysynaptic reflex, meaning more than one. It's only two, but they don't call it bisynaptic, they call it poly. The information comes in, it goes through the interneuron, it synapses with a motor neuron going out. These are the ventral roots, because that's the ventral side of the spinal cord. And that leads to the effector. In this case, the effector is a muscle. So you tap the knee, you stretch this, it sends a signal in here, goes through the interneuron, comes back out again, hits the muscle contracts, and your leg kicks. And there's a whole bunch of these that you can test in the lab. You can do that, you can do the Achilles. There's one if you want to do the triceps. Did I talk about this the other day? No, I didn't. You weren't here, right? So you can't answer my question. I'm not even asking you. Anyway, but there's one for the triceps. Of course, I can't test my own. I mean, I can take a hammer and tap it, but I can't test my own because I'm holding the muscle up. It's contracting to hold the arm up. So what you would do, you would hold the patient's arm and let them relax into your hand, and then the arm is just hanging freely, and because I'm showing you this, and then you would tap right here where the triceps inserts, and there's a little reflex point there, and it's the same thing as hitting your knee, hitting the patellar tendon, and the arm would go like that. Maybe not that much, but you'd see, you know, and it would move. So we have a bunch of these all over the body, and what you're doing is stretching that, getting the signal going through the spinal cord and back. Like I say, even an unconscious person, you don't require the brain for this. It just goes through the afferent, the interneuron, and the efferent coming out. So that's the kind of thing that the spinal cord does. Now, we have these parts here, as I say, these horns. The posterior horns are there, the lateral horns are there, and the anterior horns are here. And we're going to talk more about the anterior horn cells in a little bit. Excuse me. So anyway, that's the basic way that this is designed, the spinal cord. And as I said, here's a spinal cord in situ, in this case, a cervical vertebra. And basically that's what you would see with the roots and everything. And you'll see this, we have models that you're going to look at when we do spinal cord in the lab. Models that look just like that, exactly. In fact, they're cervical spine models. So you'll get to see that. Okay? Now, in between, we know, and we talked about this, we'll just talk about it again, since we're talking about spinal nerves, it's more appropriate. In between each of the vertebral bodies is a disc, an intervertebral disc, very appropriately named. And of course, we said that there's a fibrocartilage ring, an annulus fibrosus out here. The inside is that nucleus pulposus, the pulpy nucleus with cartilaginous cells and protein, and it's soft and pulpy. It's not hard and stiff like the annulus fibrosus, like the fibrocartilage ring. And of course, because it is built like that and not solid like the cubic symphysis disc, which is solid, or like your menisci in your knee, the lateral medial meniscus, which are solid discs of fibrocartilage, it has the option, if you treat it badly, of tearing. And once it tears, the pulpy nucleus can herniate out. So you have a herniated disc, a ruptured disc, a slipped disc. Okay, it really doesn't slip, it stays where it belongs. Herniated or ruptured disc is a little more accurate. Okay? Because it herniates. That's what's happening. You're getting this substance herniating out this way. This side is fine, but they're showing you here that when it presses on the spinal nerve coming out, it's all red, irritated, because it's inflamed, it's injured, it hurts, it's going to have pain, and it's going to have possible, depending on how bad it is, possible interference with the function to wherever this nerve goes. As I always use as an example, if you have a low back herniation, which is more common than anything else, you could be pressing on one of the spinal nerves that goes to the bladder and bowel sphincters. If that's the case, you could have bladder and bowel dysfunction in the sense of incontinence, for example, where the sphincter doesn't work properly because it's not getting the right innervation. The person could wet their pants or dirty their pants, and it's not their fault. They don't really have the full control over the sphincter muscle because this nerve is irritated. It needs to be corrected somehow. There are lots of ways to do it. Depends on how bad it is. You remember when you learned about the vertebrae, about the lamina and the pedicle? You learned those parts. Well, forget the pedicle part, but the lamina is right in this, bless you, right in this area where the nerve is coming out. So what they do is a laminectomy, which sounds like they're removing the lamina. They're not, but they shave it down. Because they don't want to play around. They're certainly not going to go in here and try to clean disc material out that close to the spinal cord, which is right there. It's the last thing you want to do, take a risk of that. So what they'll do is they'll go in and shave the lamina to make the intervertebral foramen larger. Between the two vertebrae, these spinal nerves have to exit. Now they're only showing you one vertebra, but this is coming out. And of course, this one's also herniated, and you can see it's pressing on the nerve root right there. So this guy's fine, but this one is all red and irritated, and wherever it goes, you got a problem on your hands. Now, neither of these is a cervical, as you can see, because there's no transverse foramen. So this is somewhere else, most likely lumbar. Yeah, that's what I would say, definitely this one. There's no special structures on these, so we'll say they're lumbars. And of course, that's where they usually herniate. Why? Because we're bipedal, because we're erect, and nothing in nature changed from the time we were four-legged creatures, and all the pressure was off our low back, because the low back was just down here, big deal. You're walking along. Once we stood up, the pressure is now on the low back as we stand up. So it's easy to, blow a disc or at least irritate one. You don't have to always get a herniation. You can get bulging. I'll show you that. It's coming up. I can see it's a bulging disc right there. So different, less serious, but still can be painful, is a bulging disc. And there's one that hasn't quite herniated yet, but the annulus fibrosus is definitely starting to get compromised. So you can see it's still intact here, although not as thick as it should be. And this pulpy nucleus is starting to move towards this way. Can a bulging disc irritate the nerve? It depends on the bulge. At this point, it isn't quite causing any problem to the nerve. But if the person continued to irritate it and do whatever activity it was doing this, well, I lift weights, or I'm a landscaper, and I'm always out there digging and shoveling and moving trees around. Or I'm a garbage man, and I pick up all these weights. Think about it. I don't know for other towns, but the town of Hempstead has a 70-pound limit on their garbage cans and garbage that you put out on a curb. 70 pounds, all right, that's not horrible, but that's still quite a bit. Consider if somebody weighed, okay, I'm light, I only weigh 110 pounds. 70 pounds is like 2/3 of your weight. That's pretty serious. So it's hard to move that kind of stuff. And these guys, I don't know how many women there are, so I'll say guys, not trying to sound sexist, but I've never seen a garbage woman. I've only seen garbage men. But I'm sure there are women out there doing it, but not too many. Point is, they're lifting these things all the time and throwing them in the truck. They gotta lift it up. So 70 pounds is still quite a bit heavy, heavy weight to be moving that. And you can have a disc bulge, and if you continue to lift 70-pound cans and such, it could force it into a herniation like we saw, well, here or up there, where the actual annulus fibrosis, actually tears. But this is a bulge, and there are different degrees. This is what happens to everybody with eventual age. Disc degeneration. There's a little bit of a bulge. You can see this little lump right there. But this is not caused by any particular trauma. Disc degeneration, DDD, degenerative disc disease, is not uncommon in older folks. I'm sure you've all heard the story from your grandparents, not so much your parents, but your grandparents, sitting there complaining, I used to be taller. Anybody ever hear that from a relative, right? I used to be taller, I don't understand it. Well, okay, it's one thing if you're standing like this. Obviously you're not gonna be as tall, but if you're not, you have good posture, you're standing up straight, and you still feel smaller, you probably are, not you, because you're young. But older folks, over the years, the fluid level in the discs gets lost somewhat. They get somewhat dehydrated, just with age. Now there are ways around it. There are certain vitamins that are supposed to help retain the hydration in your discs, and that'll help if we're taking these vitamins all along, even getting old. It may not cause as much of a compression of the disc. It happens. Traumas over the years can cause it. Certain lifestyles can cause it. Per particular job. Those garbage men are going to have compressed discs over the years because they're lifting all that weight. And they do it every day, 5 days a week, for years and years until they retire, say 20 years on the job of lifting heavy weights. That's going to do it. People who work out. Well, it doesn't mean not to work out, but anybody ever hear of Jack LaLanne? Did we talk about Jack LaLanne at all? Did we? Yeah, well, Jack LaLanne, when he was in his 90s, I'm sure was shorter than he was when he was in his 30s. All right? I was in great shape, but he was older. The discs tend to get compressed. Did I tell you the story about the guy in the fire department? No? So here's the story. There was this guy who wanted desperately to be a fireman. Now, all the fire departments, no matter where you go, have a height limit. Too short or too tall. They won't let you do either. You got to fit within a certain range. I didn't tell you the story. No. And this one guy was just like whatever it was that this fire department, let's say it was 5'3", he was just barely 5'3", I mean barely, on a good day. And he wanted to be a fireman in the worst way. So the story is this, and it's true. If you were to measure your height first thing in the morning when you wake up, you're taller than you are when you go to bed. And the reason is your discs plump up, they rehydrate as you sleep. There's no strain on them. You're not being pulled down by gravity. You're lying nice and flat. The discs have an opportunity to rehydrate to some degree. And of course, the thicker the discs are, the longer your spinal column, and the longer your column, the taller you are. By the end of the day, all the wear and tear up and down the stairs, lifting, straining, moving around, the discs lose some of that fluid, and you get a little shorter, but not as much as your grandparents are complaining about permanently. I can't reach that shelf anymore. Okay. This guy wanted desperately to be a fireman, and he knew there was a physical, and one of the first things they're going to do is, let me give you height and weight. Okay, if the height was okay, he could continue on. Once he passed the physical there, they'd let him do the whole, all the training, all the testing, running up and downstairs, carrying weights, doing this, doing that, to see if he could be a fireman. So what his friends did as a favor, and of course they wouldn't let the fire people see this, he got up that morning for the exam, and the first thing they did was the physical. So he got up, his friends carried him out on a stretcher. They put him in the back of a station wagon, or van. They drove him to the firehouse where he was going to take the test, and then he got up and walked in. They weren't going to carry him in on a stretcher, that wouldn't look too good. So first he sits down, he gets all the way, gets the physical, and he makes the height. He's okay, but just, so he was close. They let him run through the entire thing, running up and down and carrying this and doing that, does the whole test. He figures, that's it, I've made it, I'm okay. they call him back, and we want to measure your height again. They measure his height, guess what? All that pounding and running up and down the stairs, he was too short. Didn't make the force. That was it, wanted to get on the fire department, did not get on. Because he was too short. They said, you don't meet our requirements, I'm sorry. Poor guy was devastated, but I guess they kind of figured that it was early in the morning and maybe he'd be shorter and they wanted to see what it was gonna be like after a whole day of running around in the fire department and saving lives. So that was it, guy didn't make the force, which was the squad. Too bad, it was unfortunate, he really had it in his heart to become a fireman. Okay, different degrees of problems with the disc. As you can see here, as I said, disc degeneration, a little bit of bulging, kind of compressing it. Prolapse is a real bad bulge, it's almost ready to tear. Extrusion, that's it, you've torn the annulus fibrosis and the nucleus pulposus is leaking out. And sequestration, sequestered means to be hidden somewhere. Pieces of the nucleus are actually down into the vertebral column up against the vertebra itself. You're not seeing the cord is out here. But this is a problem because it can lean against the spinal cord. It's not going to damage it in of itself, but it could lean against it and cause problems. I had a patient that actually had that. He was a landscaper, owned his own business, so he was always digging and lifting trees and things like that. And other stuff for landscaping, so bags of rocks and things, that he had to lay out to make a nice display in somebody's backyard or something. And I treated him for quite some time, and he was good, but finally he said, that's it, I've had it. This is not working out, so I'm selling my business. And he did. He used to wear a leather belt, I remember, when he was working, and it had to give some support. But he ended up with that kind of a damage. So he left, and what he ended up, which I found very interesting, what he ended up doing was he became a custodian at a school. So I guess he wasn't lifting much, but he was sweeping and cleaning. But he was happy. He says he wasn't in pain anymore. And I haven't seen him since he became a custodian. It was fun. So I treated him for years, on and off. And I treated his mother, I treated his father, I treated his wife. So, it was a family. I treated his brother, I treated his other brother. I treated him. Just about it. Yeah, I treated the whole family. Wow, interesting. But at any rate, so they must have trusted me. I fooled them. Anyway, he had that, and as I say, giving up that job, and whatever he was doing for the school district, I guess he was able to avoid heavy stuff. And he was fine, that was it, never had a problem again. So there are varying degrees of damage to a disc. Now, this is the layout, intact, normal, of two vertebrae around the intervertebral disc. Of course, on your models in the lab, on the skeletons, or on that vertebral column that hangs on the stand. Oh, no, it's not on a stand. It's just loose on the back table. But in that, you see two vertebrae, and there's the annulus fibrosis. That's all you can see. You can't see the pulpy nucleus when it's in place. This is where the spinal nerves exit, the intervertebral foramen, formed by the arch of the superior and inferior vertebrae. Together, the two semicircles, right? They're C-shaped, but they're facing this way. They're not looking like we're going to see. They form the intervertebral foramen, and through that comes the spinal nerve. Now, as I was mentioning before, when there's pressure on the nerve, what they do is this laminectomy. There's the transverse process, but your lamina is right there, and they kind of shave it down so it makes the space bigger, because you imagine that either the bulge or the actual herniation of the disc material of the nucleus pulposus is pressing on the nerve. So how do we make this hole wider? Well, if we take that lamina and shave it down some, we can enlarge the size of the hole so the nerve has a little more room to move. And it tends to help unless the herniation keeps going on and presses further. There's just so much lamina you can take off. And after that, you really can't do it. So it is something to be considered, but in the end, they're working on artificial discs. They have some that are metallic, and they have a spring, and they put them in. It's extensive surgery, as you could imagine, and it's done from the front, right? You'd have to open the person up, push the guts aside, go to the vertebra, because the anterior, the bodies are facing anterior. They can't do it from behind. And then you take the disc out, and you put something in. Or if they're not going to put it in one of these I should have put it in my notes. Artificial discs are very interesting. They're flat plates with a spring, like that, they're metallic. They've been trying to come up with a good material that simulates a disc that you can use, but so far they haven't had any luck with that. At any rate, that's what you need is to try to maintain that space in the intervertebral foramen so that you don't put pressure on the nerve. Sometimes what they'll do if there's just no other option, if the disc is herniated seriously enough, they'll remove it. And in removing it then, you don't want bone on bone, so what they do is they take a small sliver of bone, it could be from a cadaver or even from the person's own hip, little piece of bone, and they put it between the two vertebrae like that. Remember, the disc isn't there anymore, and they use it to fuse the two vertebrae together. So you get some limited range of motion in that area. Obviously, it's not going to move like it does when you have a disc in place, but at least it stabilizes it to some degree. One of the problems is that it's not unusual for, if you do that here, over a period of time, the next one above it starts to have a problem because it's not natural to have the two vertebrae fused together and not moving. So it tends to work upward like that, and you may get continuous disc degeneration as you go up the line and having to keep doing surgeries. You really got to try to avoid it altogether, but if you have to, you have to. All right? Herniated disc repair. Let's take a look at that. There must be sound with this one. Yes. What is it? Bottoms up. Let's see what this is. Bottoms up there too. I can't imagine there's no sound. Sound is good. Should work, I don't understand, unless there's no sound with it, but I thought there was. Yeah, there's gotta be somebody talking, but there's no sound. Why is there no sound? That's the picture. Well, you can watch it. Bless you. Why is there sound? That's crazy.
Are the speakers connected to the computer?
They should be. I mean, there's a volume control here, and it's up pretty. That's for a laptop. Huh. Well, keep watching it and see what they're doing. Although I'd like that sound. It's not there. What's that?
Closed captions.
I don't know.
Go to settings.
Okay.
7 once you click on that. Okay, so.
No, no. Just quality, playback speed, and auto. That's a damn shame. They explain the whole thing. Well, like I say, watch what they're doing. Although it would be really nice if you had either subtitles or that's out. Mac. Nope. It'd make a lot more sense if you could understand what they were saying. That takes me off. Right, it's very hard to understand what's going on unless you get the sound. that sound before. Unless there's something wrong with the site. No, this really doesn't tell you anything, because you're not understanding what's going on. Well, it looks interesting, doesn't it?
Yeah, it has like an explanation on the bottom that it tells you what it's doing.
On the bottom?
And that blue line, it was telling you every step.
Oh, in
that it
here.
was- Yeah.
Well, it's not. Remove the system, okay, that's great.
Would we be able to find an actual video? If it was actually happening?
Well, this has a site. It's actually in the notes.
Okay.
This is the site that I just,
I mean like, go live.
Yeah, go live.
oh, a real line?
Yeah.
Let's see. I don't see one on here. You got this, lumbar, this is removing a lumbar disc. I see it must be-
Atlantic Spine Center
There's no
offers
problem with sound,
endoscopic
it's not
lumbar
video.
discectomy.
So it's just,
No, it doesn't, that video, that last video you just showed.
The
it
spinal
was
column or
it
backbone
doesn't have
is one of
sound.
the most
They expect
important
you to
parts of
follow
the
it
body.
without any information.
It provides the main
You
support,
tried it,
allowing you to
yes,
stand
thank you.
upright, bend, and twist.
Yeah, well, no, this is to remove the disc, not to fix it. Oh, and there's a laminectomy
33
that I was
individual
talking about
bones
too.
interlock with each other to form the spinal column. The vertebrae are numbered and divided into regions.
This you know.
C1 through C7 cervical vertebrae form your neck, support your head and neck, and allow you to nod and shake your head. T1 through T12 thoracic, that's the 12 vertebrae that are joined by ribs to form your rib cage. L1 through L5 lumbar, your 5 sturdy lumbar vertebrae carry most of the weight of your upper body and provide a stable center of gravity when you move.
Which is why they herniate more than anything else.
5 vertebrae of the sacrum and 4 of the coccyx are fused. It makes up the back wall of your pelvis. Between each of the movable vertebrae is located the intervertebral disc. Intervertebral discs consist of a thick outer layer with a crisscrossing fibrous structure, annulus, that surrounds the soft gel-like center, the nucleus. Discs function like shock-absorbing springs. The annulus pulls the vertebral bodies together against the elastic resistance of the gel-filled nucleus. When you bend, the nucleus acts like a ball bearing, allowing the vertebral bodies to roll over the incompressible gel. Each disc works in concert with 2 facet joints, forming a spinal motion segment. The biomechanical function of each pair of facet joints is to guide and limit the movement of the spinal motion segment. The surfaces of the joint are coated with cartilage that helps each joint move smoothly. Directly behind the discs, the ring-like vertebral bodies create a vertical tunnel called the spinal canal or neural canal. The spinal cord and spinal nerves pass through the spinal canal, which protects them from injury. The spinal cord is the major column of nerve tissue that is connected to the brain and serves as an information superhighway between the brain and the body. The nerves in your spinal cord branch off to form pairs of nerve roots that travel through the small openings between your vertebrae, intervertebral foramens. This is the condition of a normal lumbar intervertebral disc. As a disc degenerates and breaks down, the inner core can leak out through the outer portion of the disc. This condition is known as a disc herniation, which puts direct pressure on the nerve. Lumbar herniated disc symptoms include low back pain, legs and buttock pain, leg numbness, and tingling. Endoscopic lumbar discectomy is a minimally invasive procedure for treating lumbar herniated disc. First, a thin guide wire is placed under X-ray control down to the involved level of the spine. A tapered dilator is inserted over the guide wire. A small tube is inserted over the dilator to create a portal to the herniated disc. The endoscope is placed through the tube and the discectomy is performed. Using special instruments, your surgeon can now microsurgically remove the herniation, thereby relieving nerve root compression. The stitch or two, and the procedure is complete.
Yeah, that's pretty good, as long as that's complete.
Endoscopic lumbar discectomy include the following: minimally invasive, short recovery, high success rates, minimal to no blood loss, preservation of spinal mobility, small incision and minimal scar tissue formation. Patients are typically able to go home in a few hours. Atlantic Spine Center. Less invasive, better results.
Little advertising, but I'm not pushing this, I do not endorse anybody, but I like the video. That was good.
How do they keep it from continuously leaking? They show how they
Well,
remove.
yeah, they're taking it out, but you have to ask yourself, well, okay, what do they do to the herniate, the rip in the annulus? Nothing. So you have to hope, I guess, that it doesn't continue to ooze out, or it will over the next couple of years, and you have to do it again. And eventually you'll have no disc, and then you fuse the two vertebrae together. This must be another one of those silent ones. Okay. So anyway, well, that was interesting. I'm sorry the other thing didn't have sound. I thought it did. So here's the spinal cord itself. Okay. Now, as I said, the cord comes out from the medulla oblongata, which we'll talk more about when we do the brain. It comes down in that vertebral canal, all the way down as a solid cord, all the way down to here, to the medullary cone, which is English for the term that most medical people or anatomy books use, the conus medullaris, which means the medullary cone in Latin. And like a cone, it really kind of comes to a point. So it really does look like that at the bottom. It tapers down from the solid cord to this little point, the cone at the bottom. From that point on, it is not a solid cord anymore. And you've got all these spinal nerves here still coming out. You can see they're still coming out here. But this whole group of spinal nerves that are individual called the cauda equina, which means what? What does caudal mean? By now somebody should remember. Caudal? Caudal? Anybody? No, it's a very simple word, 4 letters.
It's a
No,
bundle.
not cord, no. Caudal? No.
It's like a bundle.
Well, you remember learning any time at all, like in the lab, something about cephalic and caudal? Never use those terms? I used to in the lab, I talk about them. Like when you talk about a 4-legged creature, they're not superior and inferior, they're cephalic and caudal.
Oh.
Caudal means tail, right?
Oh.
Okay, so now you got tail, we got one word. And the other word, equina. What is equina? Horse. Horse's tail. There you go. Thank you very much. And this looks like a horse's tail. You ever been behind a horse?
Yes.
Don't stand too close. I go over to Nassau Community College where I teach, and sometimes coming through the park, they have, because the police, the Nassau County Police mounted unit is near there. They store their horses in some stable somewhere. I'm often behind one of those trailers with 1 or 2 horses as they pull it, and I'm getting a look at a horse's butt. But they always keep their tails out. They never stuff them in there. So the tails are always hanging outside of the little door there. You can see the horse. And every time I'm riding back, I look and go, oh, cauda equina. That's me, because I'm weird. But it looks like that. It's a horse's tail. Looks like a bunch of hairs like this. Well, that becomes important. We'll show you why in a minute as far as a therapeutic procedure is concerned, or a diagnostic procedure we'll talk about. But you get that there. Now, there's this guy here, the terminal phylum, or in Latin, the phylum terminale. And that, as you can see, is attached right down there. There's the coccyx bone. So you got that phylum terminale. Now, we didn't, we talked about the nervous system, but we didn't get into the meninges yet. So the meninges are 3 layers of connective tissue that cover the brain and spinal cord only. Okay? And we're going to talk about the 3 layers of that. And you'll see where this is an extension of the innermost layer of the meninges, the innermost meninx, which is singular, called the pia mater, the soft mother, which sticks directly to the spinal cord and the brain. It's right on. Okay? So this is very important, this phylum terminale, or terminal phylum. terminal strings, basically. Because it's attached to the coccyx, and because it's an extension of this pia mater, this layer that's stuck right to the spinal cord, what happens is it anchors the cord. So the cord is sitting there, and you can do this, moving back and forth, and you don't have to worry about the cord whipping around, because the space in the vertebral column, the vertebral canal or vertebral cavity, is like this. It's bigger than the spinal cord itself. So there's room for the cord to do this. So we don't want it banging around in this. So there's two ways. This is one way of anchoring it. Anybody ever, I don't know if they're still out there. There was one in Plainview. I used to take my kids when they were smaller. These indoor mountain climbing ranges. You ever see those, right? And if you're familiar with the fact, regardless of what they show you on TV, because I saw a movie with some of these people, hey, nobody was, you're supposed to stand, somebody's got to stand at the bottom and belay, as they call it. They hold the rope, and the rope goes around the waist, and it goes up through a pulley up on top, so that the climber can't swing like this. That's dangerous. So the person stands at the bottom and holds the rope. Well, that's what the filum terminale is doing. It's holding the rope for this, to keep the spinal cord from whipping around inside. There's something else I'm going to show you in another picture that also anchors the spinal cord to keep it stable inside the spinal canal or vertebral canal. All right, so you've got that. As it says, the conus medullaris, it stops, and you've got the chorda equina, and you've got the filum terminale. There's more. Spinal tap. All right, now spinal taps are done for diagnostic purposes generally. It's not something you're going to do just a random, well, we're going to do your annual physical, so let's take a spinal tap. No. Okay? But if there's suspicion of meningitis, encephalitis, some other problem that might warrant the examination of cerebrospinal fluid, they'll do a spinal tap. And you notice it says usually between the third and fourth lumbar. Why? Because, if you remember, we said that the conus medullaris right there, that's all the way up at L1, okay? All the way up at L1, where it's no longer solid. So if you're down between 3 and 4, you're looking at the chorda equina. Now the chorda equina not being solid are just like this. So if I'm going to stick a needle through to get the sample of cerebrospinal fluid, and I'll tell you where in a bit, if I accidentally go too far and push here, it's just going to hit one of these nerves and push it aside and really not cause a problem. If I were to do it up here, where the cord is still solid, and it goes too far, I stick that needle in the cord, I'm going to cause damage. Maybe permanent, maybe not, but you're risking causing permanent damage to the person. It doesn't mean paralysis necessarily, but it could be pain forever, or some sort of a muscle twitch, because that nerve that goes to that muscle has been irritated, permanently damaged, whatever. So you don't want to do it up there, which is why they do it all the way down between 3 and 4, where it's nothing but the chorda equina, and it's easy enough to be able, even if you accidentally do it, push them aside with your needle, and nothing is going to happen. Could you nick one of the nerves? Sure, but it's less likely to cause serious damage in the long run than it would above L1, where it's a solid cord. So they don't go in there and look for it. Now, they're getting the fluid out from this thing called the subarachnoid space, and I should have had this in here, but I may have moved it out to the brain, but nevertheless, we're going to go over the meninges anyway. Now, denticulate ligaments, all right? What do you think denticulate kind of reminds you of? What English word? What? Teeth, thank you. Well, you just, Cassie's going to be my assistant because she knows all the words. Yeah, denticulate, tooth-like ligaments. These are also an extension of the same thing as that filum terminale from this pia mater, the one that's stuck, the connective tissue layer of the meninges, the meninx, that's stuck right to the spinal cord. So these denticular ligaments stick out, and they help to also anchor the cord inside the vertebral canal. So if you take a look here, there's the cord, and each one of these little, see ligamentum denticulatum right there? So each one of these little triangular guys, there, and up there, and down here, and this one you can't see, and up there, and you can't see the others here, they didn't draw it in. But they're sticking out, and they're anchoring the cord to the walls of the vertebral column. Right? They're part of this pia mater that's stuck right to the cord, and they're extensions, or thickenings, of the pia mater that come out and help to anchor. So between the filum terminale at the bottom and these little teeth all up and down the spinal cord, it doesn't bang around inside your vertebral canal. So it's easy for you to do things like this, or hey, I'm not about to do this because I can't, but go ahead and do, tumbles, cartwheels, and your spinal cord isn't getting damaged by these cartwheels because it's smacking up against the inside walls of the vertebral column. So it works very nicely to stabilize the column. Now apparently I must have left out the information on the meninges here and just put it into the brain. So just remember that for now, but when we get to the brain, we'll talk about the meninges and we'll talk about why you do where you're doing your spinal tap. There, you might want to, as I said, you saw that L3, L4, you might want to either draw off the fluid and analyze it to see if there's some sort of infection, meningitis, or encephalitis. Or you might want to inject medication into this space called the subarachnoid, which doesn't mean anything now, but it will. Because you may have to bypass the blood-brain barrier to get medication in to treat an encephalitis or meningitis, because they are protected from the bloodstream and garbage that's in your blood, which is fine if it's in your blood and gets filtered out by the kidneys and gets detoxified by the liver, but if it hasn't yet and that blood gets into either the brain or along the spinal cord, you've got a problem on your hands. Now we did talk about, when we did the nervous system, we talked about the astrocytes, remember? And we said they were there for the blood-brain barrier because those little feet help to keep things in. And we talked about the ependymal cells in the chambers and the ventricles of the brain, and that was the blood cerebrospinal fluid barrier. So you can imagine that certain medications, the molecules may be too big to get through those two barriers, and you can't get them into either the brain or the spinal cord, So what you do is you go into this space that I'm going to talk about, apparently not today, with the brain, go into that subarachnoid space, and you can introduce the medication there and bypass the blood-brain barrier, blood-CSF barrier by putting it directly into the space in the meninges that wrap around the spinal cord. And you do it down low so you don't stick the spinal cord, as I said, if you accidentally go too far. Okay, so shingles. Now you've all heard of shingles. I'm not talking about the ones that you put on the outside of your house. They're not dangerous. Shingles is, now I put adult chickenpox. It's what they call it, because it's the same virus, varicella zoster virus, VZV. And it's been said that shingles may come about from people who harbor the chickenpox virus, having had it as a kid, and it never went away. See, the problem is chickenpox virus, or shingles virus, is a herpes virus. It's nasty. And herpes viruses tend to hide out, as it says, in the dorsal root ganglion. So now you remember that at the beginning of this, we talked about that dorsal root ganglion right there. And that's what would happen, the herpes virus, if the immune system might knock it out. Let's say you had a case of chickenpox. And people have asked me, does this also go for people who got a chickenpox vaccine? I don't know, because the vaccine's been out for a while, but I don't think they followed people up into their late adult years because it hasn't been out that long. I know, listen, my oldest son is 37, and I can tell you, when they were kids, there was no chickenpox vaccine. They had chickenpox, okay? So there was no vaccine then. Maybe it's out 30 years, but if you get babies at 30 and now they're 30 years old, you can't say, well, gee, how many 30-year-olds come down with shingles? Not a lot. It's usually in older folks or somebody who's under great duress. So we don't know if the vaccine can also cause later in life a case of shingles. Let's see this, go back to the picture. Okay. Basically, what shingles is all about, as I said, it's the same virus. It really isn't adult chickenpox in that sense. I knew a guy who was like in his 50s and was a grandfather already several times over and had his own kids, 2 or 3 of those. And he apparently never had chickenpox. He said, I don't know, I guess I'm immune to it. And every time one of his kids, as they grew up, and then his grandchildren had chickenpox, he was fine. He'd take care of the kid, help, be close to the kid, kid's crying, he'd comfort the kid, kiss the kid. Never came down with it. He said, I guess I must be immune. So his last grandchild comes down with a case of chickenpox. And he says, well, I've dealt with all the other kids, never had a problem. Well, guess what? He got a case of chickenpox. Not shingles, But he did get typical chicken, all over the skin, and he even had it was in his mouth, had the two blisters in there. It was really annoying. Guy had a big beard, and they were on his face, and they itched, and you're not supposed to scratch them because it leaves you with pots, with scars, if they rupture. So you put something on like Calamine, doesn't really work, but you put Benadryl on, or you put witch hazel or something like that to help dry them up and reduce some of the itch. He couldn't get to his beard, get to the skin under his beard, and you certainly weren't going to shave the beard off because that would take all the chicken pox there and rip them up and you'd have a face full of scars. So he was a mess. But that was real chicken pox. All right. Shingles is different. It's the same virus, the same varicella zoster, but what it is, and remember that the herpes viruses hide out in the dorsal root ganglion. So for every one of these spinal nerves coming back with the dorsal root ganglion, wherever it's hiding out, that's going to be what we call the dermatome. This is the dermatome coming out. The dermatome associated with that one particular dorsal root ganglion. So when you're talking about going back here for a minute, looking at this guy, that's a typical shingles rash. Not that it can only happen here, but it's typical. I'll tell you a story in a minute. But when you're looking at this, wherever the dorsal root ganglion is, along all these spinal nerves, the nerve comes out and travels around this way and around that way and around that way and around that way. So we refer to that pathway along under the skin there, where it's going, as a dermatome. All right. So the dermatomes aren't very wide. I mean, the nerve runs that way, and the dermatome is associated with that, and then with that, and with that. So basically, when I look at this picture of this guy with a typical shingles rash, it's kind of wide from top to bottom. So I would have to say that it's at least in 2, possibly even 3 dermatomes, because the nerves are here running along. One's probably running along there, and the second one maybe through there, and a third one down here at the bottom. So probably 3 nerves, 3 dorsal root ganglia had harbored the virus on this guy. Now what brings it about? Well, stress. Emotional can do it. Physical can do it. I'll tell you 3 stories of shingles. One was a patient of mine. I treated her for years, for her back and on and off, and she was fine. She was the mother of one of my original patients from the clinic who followed me and then brought her mother in, and her father, I treated him too. And one day she calls me and says, "What can you do for shingles?" I said, "Well, never really done anything, but I had some ideas." So I said, "Well, why don't you come in? Let's see what we can do." Now, I wasn't going to touch it because I put gloves on. Because even though I've had chickenpox, and it is the same virus, it can be contagious. You've got to watch. You don't want to get it in your skin. And it did look like that, and these little blisters ooze out live virus. So you treat it, you use gloves. I said, "All right, do you have any idea how this happened?" She said, "Yes, I do, actually." She says she and her husband went on vacation, went up into, it was winter, they went up to a mountain, a nice ski lodge type place. I don't think they did any skiing, but there was a nice lodge there and a nice fireplace, and they went up for a walk up the mountain path, and they stood up at the top of the mountain there, associated with the lodge, and they looked out over this beautiful scenery, but it was cold up there, it was winter. And she said, "I got a chill." I said to my husband, "Let's go back down to the lodge. I want to warm up. Maybe I'll have a hot cup of coffee or something." So she went back down, and she felt chilled, and she had coffee, and she had hot soup. And it took a good half hour to 45 minutes to finally get rid of the chill. Well, within a few days, she came down with this rash. This isn't her, but it looked just like it. All right? So that's when she called me, and I said, well, knowing where it hides out, I said, "Come into the office, let's see if we can try something." And I came up with this wacky idea of using a muscle stimulating machine with 80 pulses per second that we use to relax muscles. And I put the pads, she looked, actually I think it was the same side too. It wasn't both sides. You see, his other side's clean. It doesn't have to be both sides. I put the electrical stimulation pads way here, close to the spinal column. And I said, "Let's see what happens." And I cranked up this electrical stimulation until she couldn't stand the pain anymore. I said, "Tell me when it hurts, and I'll just make sure it's not quite at that level of I can't stand it." We brought it up where it was. I'm going to sit there for 15 minutes. My theory was that since the afferent nerves, going back to the spinal nerve, remember it's two-way traffic, the afferent nerves are picking up this electrical signal, and it is in the dorsal root ganglion, which is the afferent nerve, that these guys are hiding out. I said, what if I shot them, gave them electricity? So I treated her, and a couple of days in a row, and by the third day, she had no pain at all. Still had a rash, but had no pain. She said, this is wonderful, pain's gone. I said, okay, it's interesting. Sometime later, not that many weeks later, one of my other patients I was treating for migraine headaches said, my husband has shingles. I said, all right. So he came in that Monday, and he comes in, looks just like that. And he says, it hurts. And, oh, by the way, Thursday I'm going to South Carolina to a golf tournament. Can you get me over the pain because I can't swing a golf ball? I said, could we give me a little more notice? So I said, well, it worked for the lady. So I started treating him every day, Monday, Tuesday, and Wednesday with the electricity. By the end of Wednesday, he said, I feel great. Thursday, he went and left. I never saw him again. So his wife said, how's he doing? She says, he's out of pain. Still had the rash, but he didn't care. The rash didn't stop him from swinging the club, so I don't know how he did down in South Carolina, but he was down there. I said, this is really neat, but that's only 2 cases. And if you're writing a paper, you can't write a paper based on 2 cases. It's not statistically significant. So, never followed up on it. Haven't treated anybody else for shingles. And used my little electrical machine. Okay, so I need to find a school or a hospital that's willing to fund a study. I'll run it, and then I'll write it up. I can do that, but I have to have enough cases. So if they were to, say, set up a room with a bunch of tables, they don't even have to be chiropractic, they're just tables to lie on, and a bunch of these therapy machines, and you stick them on there and say, okay, we're gonna treat it, and see how it works. You know. Wanted, patients with shingles, come see us, we'll treat you for free. Who knows if it works, but as I said, 2 out of 2, that's 100% success rate. If I lied and said it was 20 out of 20 or 200 out of 200, I could write a paper.
That's twice now that you've had those situations where you discovered something
And couldn't do anything about it.
Yeah.
The other one was the muscles, right?
Yeah, with
the law student.
I think it was the scoliosis.
Oh, the scoliosis, that's true. And then
So
I had
I
a
guess 3.
law student come in, and I was treating her, and I was using my machine to build up her muscles. And she said, well, could you use this anywhere? I said, yeah, anywhere you have muscles, like she wanted to tighten up thighs, you know, and I said, sure, you put the pads, if the pads fit properly. It's hard with these little round pads and a strap. But I said, if you had like a sleeve thing that came over your thigh and hooked up to the machine, you could build up those thigh muscles and get them to tighten up. And abdomen, sure. I said, you put it on your abs, and this was years ago. And I never did anything about it, and sure enough, they came up with these ab things. And one of my students came in the high school I was teaching at back in like 2000, and he said, look at this, and he wore this thing. I said, what's that? He says, this is it. He has battery operated, and it tightens while I'm sitting here in your class. I'm tightening up my abs. He says that, and I'm saying, Jesus, man, I could have been a millionaire. I wouldn't be here now. I'd be sitting in my boat somewhere in a nice warm climate. So, yeah, I keep losing it. Just 3 times, 3 different situations. It's sad. Okay, anyway, now, polio, another disease. By the way, if anybody knows anybody who's willing to fund a study, I'll be happy to work it out. I'll write up the protocol. Polio virus. Now, thank God for vaccinations. Now, I know, is anybody here anti-vax? No?